really need this anyway. But so my name is Susanna Nagy. I'm the Director of Infectious Diseases Research here at the DCRI. I'm a faculty member over at Duke and ID, and I am thrilled that Dr. Bartlett has agreed to come speak with us today on a day I think that many of you know is World AIDS Day. And it's amazing to think about the history of HIV and the treatment of patients with HIV over the past 30 years or so. I am standing up here, someone who came into this very late in the game, and therefore, to be fair, don't have a great understanding of how difficult it was back then, because I came in at a time where I could give a patient a single pill and say, you know, this is not going to be your big problem 10, 20 years from now. But I think it's unbelievable for Dr. Bartlett, who started his training before we knew what HIV was. And I'm going to say this, even though I don't know this for sure, but I imagine this is true, which is that there are many folks like him who were training on medicine wards around the country when patients were coming in with this disease that no one understood, no one knew what it came from, and it changed them. And who knows what many of them thought they were going to do in the beginning, but as they watched this evolve and they saw what happened to patients, it made them decide, I'm going to go into infectious disease and treat these patients for the rest of my life. And I think for many of these people, this is not just been a career, but it's been a lifelong dedication to understanding this disease, this infection, the diseases it causes, and managing the patient. So, you know, I could give you all of the things that he's done, which are ridiculously many, but here at Duke, you know, he has been really the leader of HIV research. Our AIDS clinical trials group site PI for over 20 years. He's also the co-director of our Center for AIDS Research, which just got an unbelievable score and will almost certainly be refunded, which made us all very, very happy, and will continue to lead the way in HIV research here at Duke. He also really has been a leader in HIV research outside of the United States, and has had a long-standing relationship in Moshi, Tanzania, where he has done unbelievable things there to benefit folks there, not just in terms of patients, but in terms of training providers there, training researchers there, maintaining infrastructure for a center that's been a leader in HIV research outside of the United States. So without further ado, I will introduce Dr. John Bartlett and look forward to hearing him speak.
Thank you. So thank you, Susanna, for that kind introduction. So today what I'm going to do is I'm going to talk for probably about 35 or 40 minutes, and then hopefully we can have a dialogue and a good exchange of ideas and questions. But what the topic that I'm going to take on is HIV infection in 2014. Is an AIDS-free generation possible? And I think it's topical here on World AIDS Day to have this kind of a talk. World AIDS Day was started in 1988, so this is the 26th World AIDS Day. And as we reflect on that, it's important to remember that 36 million people have died from AIDS, so it's taken quite a substantial toll. The other point I wanted to make here, even though this is not the best picture of Mount Kilimanjaro, is that I'm going to speak from a global perspective. So I'm going to talk some about local issues, and I'm going to talk some globally. So in terms of my competing interests, most of my salary support comes from the U.S. National Institutes of Health. I serve as the global health editor for Up to Date. I'm a DSMB member at the Harvard School of Public Health, and I'm a DSMB member for Sera Therapeutics. They have no HIV-related products. But in the interest of transparency, those are the compensated activities that I have. So my objectives for today include providing an update on domestic and global HIV infections. I'd like to share with you some new developments in HIV prevention and treatment. I'd like to share the goal with you, this whole concept of an AIDS-free generation. And then I'd like to highlight some outstanding opportunities for HIV-related research at Duke, especially those opportunities that are interdisciplinary. So as Susanna alluded to, I have had the privilege of seeing my career co-evolve with our understanding of HIV infection. So I'm going to take this opportunity to be somewhat philosophical in today's talk and to share with you some of the historical perspective on HIV infection. So on July 3rd of 1981, I had just graduated from medical school, and I was an intern on 4300 in Duke North. Duke North had just opened. And so this description came out. At the time, if you were a trainee, MMWR was free. And so I received this and read about these reports of young gay men who were being diagnosed with Kaposi's sarcoma and pneumocystis carinii pneumonia. And it was shocking. Then over time, we began to see patients who had clinical AIDS here at Duke. My first patient was 1982. Then I can recall rounding in 1983 with Bart Haynes on the rheumatology consult service. And Bart said, "John, it's so exciting. We're working with Gil White at UNC and the Hemophilia Center. And we've identified antibodies to an HTLV, human T lymphocytotropic virus." And he said, "We've identified antibodies in all these patients with hemophilia, and we think we found the cause of AIDS." So that happened here at Duke. In 1984, I was working in the lab with Kent Weinhold in the old animal isolation facility, and Kent came out of the lab and screaming to me, John, we have a compound that's demonstrating activity against HIV, in vitro activity." And that was so-called compound S, which had been sent by Burroughs Wellcome to Kent to have an independent evaluation of its activity. Then I can recall in 1985, when the second patient in the world with HIV infection received AZT here at Duke. I can recall when Tom Matthews discovered the activity of enfuvertide, or T20, in vitro. I can recall being at the conference on retroviruses and opportunistic infections, sharing the podium for a late breaker session with Trip Gulick, the day that he presented information that a 3-drug combination suppressed viral loads below the limits of detection. What was tragic is I had to follow him. And so everybody was quite disappointed with my talk. But all of these things, this history has just been incredible. And then how care has been transformed over time. Many of you will recall in the 1980s and early 1990s, a lot of the care that we delivered was focused on palliation and empowering patients in that terminal phase of their lives. 1995, 1996, the introduction of protease inhibitors and combination therapy, all of a sudden we began to look at long-term survival. So it's remarkable how that story has changed. So what I'd like to do in the beginning is to share with you some updated information with regard to domestic HIV infection. So it's still somewhat shocking, but there are between 40 and 45,000 new cases of HIV infection occurring in the United States each year. And if you look at the trends here, you can see that they're pretty stable. Despite all our efforts at providing care, despite all our efforts at public education about prevention, there are between 40 and 45,000 new HIV infections in the United States. And it's not changing. And if you look, there's a disproportionate number of men, and we'll unpack that and understand that. And there continue to be a stable number of women. So here we're looking at the HIV risk behavior associated with new diagnoses of HIV infection. And as you can see, 64% is related to men having sex with men. Now, this community is empowered. This community has access to lots of prevention information and prevention methods. But we continue to see that almost 2/3 of the new cases of HIV infection are amongst MSMs. So this is really, it's kind of shocking. So there continue to be high-risk behaviors within this population. And then if you follow the rest of the graphics, you can see here 17% is among women who had heterosexual contact with someone with HIV infection. So this is what we're seeing in terms of epidemiology of new HIV infections in the United States. Now, if we look further to understand which groups of people, which populations may be at highest risk, we see the overrepresentation of minority populations, of African Americans and also Hispanics and Latinos. So here, 42% of the men with newly diagnosed HIV infection are African American. If we look at female populations, you can see that percentage increases to 64%. So we have some idea about the populations who may be at highest risk. Well, what about in terms of geographic distribution? Well, if you look at what's happening here in terms of incident rates, rates per 100,000 population, you can see that the U.S. South is quite profoundly impacted by HIV infection. Here we are in North Carolina with 18.1 cases per 100,000. Look at Georgia, 49.6, really shocking. And if you talk with colleagues in Georgia, they see huge numbers of patients in Atlanta, especially among the young MSM population. So the U.S. South has really become the epicenter for the HIV epidemic domestically. Now here we're looking at AIDS classifications and deaths of persons with HIV infection. And as you can see, around the mid-1990s, these curves started to decline. So this is fantastic. Fewer people are progressing to full-blown AIDS, and in addition, fewer people are dying of HIV infection. But there are some disparities in terms of access to some of the benefits associated with routine care. And here we're looking at the same data, but broken down by race, ethnicity. And as you can see, in the white population, death rates and progression to AIDS have declined quite significantly. The African American population has seen some decline, but they haven't seen the tremendous benefit that other populations have. And I think understanding this is challenging because the reasons are quite complex. There's no simple reason, but much like many other health outcomes, we see profound racial disparities in terms of the benefits of treatment. Here we are looking at breaking down amongst African Americans the risk behaviors associated with HIV infection. And you can see that 74% of the men have a history of sexual contact with another man. And we're aware that MSM behaviors are associated with significant stigma, especially in the African American community. So here's a population, if we want to have targeted prevention messages, here's a population where we would have substantial potential for impact. And then amongst African American women who are diagnosed with HIV infection, heterosexual contact is the leading risk behavior. Here we're looking at percentages at progression to AIDS by race and ethnicity at the time of diagnosis. And so what this means, as you can see, the percentages for African Americans are higher, and what this reflects is a late diagnosis. So they're more likely to be diagnosed with stage 3 or 4 disease than earlier disease. And in other populations, this percentage has declined. So this is a challenge. The treatment for HIV infection is most successful if it is started early. Now here we're looking at the rates of death amongst people diagnosed with HIV infection. And as you can see, again, the disparities in terms of the benefits of care are profound. Here in the African American population, it's 21.7. Contrast that with the Caucasian population, where it's tenfold lower. So death rates are much higher for minority populations. Again, the reasons for this are quite complex. So I thought I would offer to you a snapshot of what is happening in the Duke Adult Infectious Diseases Clinic. As you can see, we have about 2,000 patients that we take care of. 28% are women, and this is pretty much spot on with the percentages in North Carolina. 57% are African American, 4% are Latino. This is a phenomenon that's being seen all across the world, and that is that the patient population that we're providing care to is aging. And this is important because one of the things that we'll come back to is that HIV infection itself seems to accelerate the aging process. And so as our patients get older, we're seeing different comorbidities such as cardiovascular disease, stroke, neurological complications, and again, we'll come back to this. Our patient population is really thriving in terms of treatment. 53% have CD4 counts above 500. 500 is the threshold for a normal CD4 cell count. 86% have CD4 counts above 200. And 200 is an important clinical threshold because below this value, you start to see complications of AIDS. You can see the mix of private insurance, Medicaid, and uncompensated care that we take care of in the clinic. Well, now what I'd like to do is, now that we've discussed what's happening domestically in terms of HIV infection, I'd like to take a few minutes and talk about global HIV infections. So there are an estimated 35 million persons living with HIV infection globally. 22 million are in sub-Saharan Africa. It was estimated in 2013 that there were 2,100,000 new HIV infections. And what's significant about that is it actually has declined 38% since 2001. Can I tell you what's responsible for that? No. Because it's probably a complicated mix of things: human behavior change, prevention methods, treatment of patient populations, and because we'll talk about this more, if you have a serodiscordant couple, if you treat the HIV-infected partner, that decreases transmission risk to the uninfected partner. 1.5 million deaths from HIV infection in 2013, which is down 35% from the peak in 2005. That's pretty remarkable. And then there are a number of studies now that have documented declining seroprevalence in Eastern and Southern Africa. So this is a hopeful message. Well, what about prevention methods? Well, what's kind of exciting is in 2014, we really have a number of different prevention methods that we can offer. And now, just like 20 years ago, the emphasis became on combinations of antiretroviral drugs. Now in prevention circles, the emphasis is on combining prevention methods. So testing by itself can lead to a change in behavior that can be associated with decreased risk of HIV acquisition. Condoms work if people use them. Male circumcision, I'm going to talk about a bit more. Pre-exposure prophylaxis, I'm going to talk about quite a bit more because it's really a complicated topic. Microbicides, there now has been one trial that has identified benefit to a vaginal microbicide used by women, applied before intercourse and again after intercourse. This particular microbicide contains tenofovir, which is an antiretroviral medication. It's likely that there will be continued successes in the field of microbicides, and microbicides will probably contain combinations of antiretroviral drugs. Then I'll talk a little bit about vaccines. Well, I was quite impressed that there now have been 3 randomized trials of male circumcision amongst HIV negative men that have demonstrated consistent benefit, a decrease in risk by 60%. And for here at DCRI, to see 3 randomized trials show an exactly consistent result is kind of amazing. But it was absolutely consistent across the studies. Quite encouraging. Now let's get into the topic of pre-exposure prophylaxis, which, as I alluded to, is really complicated. Well, the first study was the IPREX study. Let me clarify. What pre-exposure prophylaxis means is if you're HIV negative, before you have an anticipated high-risk sexual contact, that you would take an antiretroviral medication that hopefully will protect you during this sexual contact. And so there have been a series of studies that have been performed. The first one was the IPREX study, and it was done amongst men having sex with men, and it demonstrated that a combination of 2 antiretroviral drugs, tenofovir and FTC, decreased the risk of acquiring HIV infection. So this was important in terms of public health benefit. A second study, the FemPrep study, was done amongst heterosexual women, and it failed to demonstrate any protective effect. So the investigators went back to the women who participated in the study, and they looked at the drug levels that were being achieved in the bloodstream of the participants. And they found that the levels were subtherapeutic. They then looked at the adherence measures that had been incorporated into the study, and they found that those women who had subtherapeutic levels weren't taking the medication. So this was a failed study, but there was an explanation. Now, furthermore, there have been some analyses done looking at drug levels that are achieved within vaginal secretions and vaginal tissue. And they have found that the drug levels of FTC and tenofovir that are achieved in that environment are considerably lower. So there was some speculation that it was not just simply a matter of adherence, but that perhaps the penetration of drugs into the vaginal mucosa was not as robust as perhaps was being achieved in the anal mucosa, where therapeutic levels of drugs were seen. It seems biologically plausible. But then a second study was done in Botswana amongst men and women who were receiving FTC tenofovir, and a decreased risk of HIV acquisition was seen, both in men and in women. And then finally, there was another study done, Partners PrEP, that looked at tenofovir alone and the combination of tenofovir and FTC, and again demonstrated that PrEP was successful. So how do we implement this in terms of public health planning? I think it's pretty challenging to know how to prescribe PrEP. I've prescribed it a single time. It's expensive. Will insurance companies, other third-party payers pay? There are quite a few legitimate questions that come up. What impact will this have on the global HIV epidemic? I think that remains to be seen. And this is really where implementation science or operations research becomes critically important. You have to look at populations over time. Will resistance emerge? It didn't in the randomized controlled trials. Will it happen in a bigger population? Not sure. What will happen in terms of disinhibition of risk behavior? All of these are legitimate questions. Now I'd like to tell you about HPTN, HIV Prevention Trials Network 052. I think this has substantially more public health implication than the results of PrEP studies. And this was a study that was done in over 1,700 HIV serodiscordant couples. So one member of the couple was HIV infected, the other was HIV negative. And the seropositive partner had to have a CD4 count between 350 and 550. They were randomized to either early antiretroviral treatment or delayed treatment. And if people had a decline in their CD4 count to less than 250 or a clinical event, they crossed over to go on active drug. Now, when they designed the study, they were very clever because they included sequencing of the HIV strains between members of a couple where transmission occurred. And in that way, they could ascertain whether the virus that caused the infection in the negative partner came from the seropositive partner or there was a third party involved. And this will turn out to be quite important. The study was stopped by the DSMB after 1.7 years, and 90% of the couples were still in follow-up. So overall, there were 39 transmission events, 4 in the early therapy group and 35 in the delayed group. So as you can see, this was highly statistically significant. Now, when they looked by analyzing the sequences from the viral strains that were transmitted, they found out that 11 times there was a third party involved. And when they focused on the 28 linked transmission events, you can see there was only 1 in the early therapy group versus 27 in the delayed therapy group. So the relative risk reduction was a 96% risk reduction. So in addition, in this context, what other things have happened in terms of progress on prevention? Well, there now have been a number of household surveys that have documented increased HIV-related knowledge. They have documented increased condom use. They have documented fewer sexual partners before the age of 15. And they have shown decreased numbers of adults reporting multiple sexual partners. There has been a massive scale-up of male circumcision, and 6 million men in sub-Saharan Africa have been circumcised since 2007, including 1 million in 2013. Then a major, and we'll come back to this, advance has been the scale-up of combination antiretroviral treatment for pregnant women and postpartum women who are breastfeeding. And this is now known commonly as option B+. But this, we'll come back to this, this has the potential to truly eliminate pediatric HIV infections. Now, there was one vaccine trial that did demonstrate decreased risk of HIV transmission. This was a trial that was done with a heterologous HIV vaccine. It was done in Thailand, and it demonstrated a modest reduction of risk of about 30%. Now, the group here at the Duke Human Vaccine Institute has been working quite closely with the supporters of this vaccine study to try and understand why this vaccine demonstrated protection against HIV acquisition. They've published a whole series of articles, and I think we can all be quite proud of the work of the Duke Human Vaccine Institute because they are truly pushing back the frontiers of vaccine science. Well, now let's talk for a few minutes about antiretroviral treatment. There are, as you can see, 7 different classes of antiretroviral drugs. One of those classes, I mentioned earlier, the fusion inhibitors, they were discovered here at Duke by Tom Matthews. But you can see now that there's quite a menu of different treatments that we can offer to patients. Now, I think there are a number of important trends when we think about antiretroviral treatment. When I went to medical school, this whole idea of combinations of drugs, of fixed-dose combinations, was heresy. I mean, it was like the worst thing you could do to patients because they could have different toxicities. You couldn't change the dose in that fixed-dose combination, and so they were very much avoided. Well, with time, we've come to see, at least in the context of HIV infection and perhaps with the polypill and cardiovascular diseases, that fixed-dose combinations reduce the pill burden and that may have an impact on adherence. And so now in many environments, you'll see that there are regimens as simple as 1 pill a day. So it's fantastic how simple things have become. Now in the North, we can usually construct 3 successive antiretroviral treatment regimens. So if 2 regimens fail, we can still come up with a 3rd most of the time. And the anticipated lifespan is 40 to 45 years after starting antiretroviral treatment. And this is remarkable because back in 1985, the median survival after being diagnosed with full-blown AIDS was 24 weeks, less than 6 months. So it's really fantastic that we've gotten to this point. And as we'll discuss, in low and middle income countries, you can usually put together 2 successive regimens, which gets you quite a bit of this benefit, the 40 to 45 years of longevity. One challenge in low and middle income countries is that there is essentially no viable means of following the success of antiretroviral treatment. If you do it with CD4 counts, if you do it with clinical indicators of progression, it's like flipping a coin. Half the time, if you see changes, half the time the patient is still virologically suppressed, and half the time they're not. So what we desperately need is some method of having viral load monitoring in resource-poor settings. It's critically important. Lots of smart people are working on this to try and develop a point-of-care assay for viral load testing that's inexpensive and can be used in the field. But for the vast majority of patients, there's no monitoring of the success of treatment. And as I mentioned earlier, in low and middle income countries, we can come up with 2 successive regimens, but there's not a 3rd regimen. Well, what are the WHO treatment guidelines? And they recently changed in 2013, and I think it's interesting how they've changed. Anyone who has symptomatic clinical disease should be treated with antiretroviral medications. Anyone with a CD4 count below 500 is recommended for treatment. Now, I can tell you in virtually all low and middle income countries, the second criterion is not being adhered to. They simply can't afford it. Anyone with HIV and TB should receive antiretroviral treatment, and there's a good evidence base to support this. Persons with HIV and chronic hepatitis B should receive treatment. Now, in most low and middle income countries, we don't see a whole lot of hepatitis C. We see much more chronic hepatitis B. And chronic hepatitis, whether it's B or C, can accelerate more quickly to advanced liver disease. It can cause immune activation that can progress HIV disease more quickly. So there's a good rationale for treating patients with HIV and chronic hepatitis B or C. The WHO recommends treatment of all serodiscordant couples. This has profound implications in terms of that randomized controlled trial that demonstrated a 96% decrease in risk of HIV transmission in a serodiscordant couple when one is on treatment. Now, WHO is recommending treatment for all pregnant and breastfeeding women. And again, in many areas now where testing is happening, where treatment is available, the risk of perinatal transmission has declined to less than 2%. This is awesome. This is our best hope for an AIDS-free generation. Our best hope. And then all children under 5 are recommended for treatment, again, because a survival benefit has been demonstrated. So what is the global status of antiretroviral treatment? Well, as you can see, there are now 13.6 million persons living with HIV infection on treatment. This is phenomenal. It's fantastic that this has been achieved. But it's still falling short. Antiretroviral coverage in HIV-infected adults is 38%. In children, it's even lower at 24%. So we have a long way to go. As I alluded to earlier, Option B Plus implementation in Tanzania has lowered perinatal transmission rates to less than 2%. And in 2013, all of this reflected an investment of $19.1 billion in low and middle income countries to prevent and treat HIV infection. Well, you may say that's awfully expensive, but I think the cost of inaction is predicted to be significantly higher. What is happening in terms of transitioning the cost of treatment to in-country ministries of health? Well, now 60% of the burden of procurement of medications, 60%, has been transferred to host country ministries. So groups such as the Clinton Health Access Foundation have done a fantastic job in terms of bargaining with industry and getting decreased prices to be able to make these medications affordable. Industry has been more or less cooperative with this, and that's good. And so it really has made antiretroviral treatment in the global context much more available. Well, where is it all going? Well, UNAIDS has something called the Fast Track Report. And this Fast Track has the goal of ending the AIDS epidemic by 2030. Well, what are some of the key components? Well, by 2030, they're hoping that 95% of HIV-infected persons know their status. Where do we stand currently? About 25% of HIV-infected persons know their status globally. The second critical factor to achieve this success is that 95% of HIV-infected persons will be on ART. So I mentioned earlier, we estimate that there are 35 million HIV-infected persons globally. That would mean having 34 million of them on treatment. close to 34 million. That's going to be challenging. Then they're assuming that you can suppress virus load in 95% of the treated people. Well, what do cohorts look like now who are receiving antiretroviral treatment? Most cohorts in low and middle income countries demonstrate that between 65 and 85% of people on antiretroviral treatment have fully suppressed virus load. So this is a pretty tall order. But if we're able to achieve this, they've estimated that there'll be 28 million new HIV infections that are averted, including 5.9 million in children. They estimate that there would only be 200,000 new HIV infections in 2030. And remember, this past year it was 2.1 million. And they have estimated that there would be a 15-fold return on investment. They further have some modeling that if we don't continue to scale up, in essence, all we're doing is shifting the curve a bit, and we're going to start to see increases. So they would suggest to us that this is an investment that we need to make. So what are some of the challenges to ending the AIDS epidemic by 2030? Well, I think the top bullet point is really critically important. We currently have poor linkage and retention in care. So if you look now at someone who is newly diagnosed with HIV infection in South Africa, what is the likelihood that they'll be on treatment? They'll know their CD4 count, one of the principal determinants of need for treatment, that they'll be prescribed treatment, and they'll be in follow-up a year later? It's 1 in 6. 5 and 6 don't get through this cascade. So if you want to think about opportunities for operations research or implementation science to make a difference, this is an area where it could dramatically impact public health. And there are many, many, many people focused on this. The lack of affordable viral load assays is a real challenge because if you can't monitor the success of treatment, you can't ascertain the failure of treatment and move someone on to a second-line regimen. Now, there are many people who are focused on this. Abbott and Roche have discounted the prices. They're the two leading manufacturers of viral load assays. They have discounted their prices on reagents. So now in a high-volume laboratory, you can get the price down to $10 to $12 per assay. So that's substantial progress, but it's still quite expensive. And many locations don't have access to such a sophisticated laboratory. Another challenging point for the HPTN 052 study are the RCT results on antiretroviral treatment as prevention applicable to larger populations. So again, once you put this not in a very supportive environment of an RCT, do you still continue to see such benefits? The downturn in the global economy has taken a toll. It's more challenging now to get people in the north to donate to help people in the south. And the donors are getting tired. There are competing global health priorities. We live in a world where NCDs, non-communicable diseases, are becoming epidemic. And we have competing priorities that have substantial merit and need. And then finally, I think the most consistent and universal issue that you face in the context of HIV infection is stigma. It is absolutely global. It is a profound obstacle to care and really challenges us to be creative. What about HIV cure? Here domestically, you'll hear a substantial emphasis on the cure of HIV infection. There is one patient who has definitely been cured. He was a gentleman who had refractory lymphoma. He underwent bone marrow transplantation. He received donor marrow from a sibling that turned out to have a CCR5 32 base pair deletion mutation. And so this is CCR5 is one of the important co-receptors for HIV infection. And so he was incredibly lucky to receive a marrow that made him inherently resistant to HIV infection. And it appears that he is truly cured. So this now, and there have been some reports of early treatment of infants with antiretroviral medications. Some of those reports have, with additional follow-up, the so-called cure has not been confirmed. There is a substantial effort now to find a cure for HIV infection. UNC has one of the funded centers to try and achieve this goal. Many of these investigators are focused on how they can activate the latent pool of HIV-infected cells. And so HDAC inhibitors, histone deacetylase inhibitors, have been identified as a class of drugs that seem to have properties that lead to HIV activation. Then the idea is if you activate virus replication in the context of fully suppressive antiretroviral treatment, that you could eliminate some of these cells that are chronically infected. And that could be a step towards cure. Is cure going to be something that's achievable for the vast majority of persons with HIV infection? I tend to doubt it. It might be accomplished in a few limited circumstances. We have some wonderful opportunities here at Duke to engage in this kind of research. DHVI and HIV vaccine research is incredibly high profile, and if a vaccine that's effective is going to be discovered, I think it will happen here. The CFAR database and biorepository is an incredibly useful tool for those of you who want to engage in research with HIV-infected populations. There are 8,000 unique patients and 40,000 plasma specimens in this biorepository, and Susanna Nagy is in charge of this. And she's very cooperative and would be happy to share information and specimens. We now have a number of interdisciplinary teams that are focused on trying to understand HIV infection in aging, and in particular the risk of cardiovascular disease. So Swati Shah has a pending R21 application. Jerry Bloomfield has an R01 application going in January. Eric Velasquez is very much engaged looking at HIV and congestive cardiac failure. Bill Krause is engaged. Susanna has access to the VA database, the national VA database. So there are fantastic opportunities for interdisciplinary teams to address cardiovascular disease. John Stanifer and Upta Patel are focused on chronic kidney disease, including in a global context. Mary Klopman's laboratory-based research is focused on this. Mary McKellar in infectious diseases has been working with the Aging Center to try and understand issues relating to frailty and neurologic disease in an aging population. In addition, Kathy Sikkema, Christina Mead, others have been focused on some of the mental health aspects of HIV and aging. Then Monica Kraft, David Murdoch, Devin Paul, who's here, and others have been focused on COPD and asthma and the intersection between lung disease and HIV infection. So it's really fantastic to see all these folks coming together and taking these opportunities to investigate the pathogenesis and clinical management of some of these complications. And then, of course, we have the important topic of co-infections. Susanna was waiting for me to mention this. She was going to kick me with her boot if I didn't. Certainly, hepatitis C is incredibly important. We have others who are focused on tuberculosis and other co-infections. Malignancies, we have a group that's focused on HIV-associated malignancies. Mental health I mentioned, and we have an increasing number of people who are doing some cure research. As I alluded to during my talk, implementation science, there are fantastic opportunities to evaluate how some of these interventions perform in the field. So what conclusions would I offer to you? I would say domestic HIV infections are continuing, and they can be especially identified in certain populations of men having sex with men, and African American populations seem to have a higher risk. Globally, there are encouraging trends in the epidemiology of HIV infection, likely due to multiple factors. I don't think we can isolate a single factor as being responsible. ART rollout has been quite successful to date, as I mentioned, with 13.6 million people on treatment. The end of the AIDS epidemic faces many challenges, and we have outstanding opportunities here locally to engage in making a difference. So with that, I'll close and be delighted to take your questions and comments.
So maybe I'll start. Would you, maybe just for the audience, given how long you've been doing this, just talk about the conversation you have with a patient today who comes in with a new HIV infection? And because it's still, as you said, the stigma is still unbelievable, especially in select populations in this country. And it's devastating to hear the stories that I still hear today of how patients' families treat them when they're diagnosed and things of that sort. And they're terrified when they come in, but the story is quite different today than it was, 25 years ago.
Yes. So some things are the same and some things are different. So I would agree with you clearly that stigma is still an incredibly profound issue, and helping to talk through patients and their significant others and their family members is really essential. Some discussion of potential transmission to future sexual partners is important. Some of that has stayed the same, some of that has changed. Certainly, discussions regarding prognosis are dramatically different. We now have a much better understanding of the importance of comorbidities, especially mental health and substance abuse. And we know that if a patient is depressed, they're less likely to adhere to medications. We know if they're abusing alcohol or cocaine, they're less likely to be adherent to their medications. So some things have changed, some things have stayed the same. I don't often get the question anymore, when am I going to die? And I used to get that all the time. And I'll never forget, I had one wonderful patient. He kept pushing me, saying, John, I have to know how long I'm going to live. And I tried to divert this and defer on an answer. And finally, he just so annoyed me, I said, well, look, the median survival is 6 months. And he went promptly home, went to the gym, started lifting weights like crazy. And 6 months later, he came back to me and gave me an extremely hard time, because he was definitely more fit than I was.
I think I know that patient.
Yes, Talia.
John, I just wanted to mention, I know you talked a little bit about the global cascade of care, but I wanted to talk a little bit about the cascade of care in the U.S.
Yes.
And just the fact that there still is a real problem in getting people, number one, tested, and getting them into care and retaining them in care. And that this is not just something that happens in South Africa, that this is happening here in the U.S. as well.
Sure, and it's an incredibly important point. Amongst those people with HIV infection, only 25% are retained in care and have a suppressed virus load. That's 1 in 4, which is not that much different than 1 in 6. So it's an excellent point. And again, it's an area where implementation science research can make a difference. Yes, sir?
You mentioned that you prescribe PrEP once, and I wanted to know how often are you asked for a PrEP prescription, and what is your reluctance to prescribe it?
Yeah, it's a really good question. And so I think one thing I have observed amongst treating physicians is there was some reluctance to accept the use of PrEP, and that could include a bias that we bring to the interaction regarding being realistic about continuing unsafe sex. Another one could be a concern and apprehension about drug resistance. And I think with regard to the first, with regard to the bias, the CDC has had quite an aggressive campaign to promote PrEP and to try and encourage acceptance amongst providers of care. With regard to the second issue, I think all of us are reassured to see continuing follow-up of patients and that resistance does not appear to be a significant issue. I think the final factor that's challenging is payment. And I think because PrEP is so expensive, many patients are a priori excluded because they don't have a third-party payer. So those are some of the issues that I have faced.
Yeah, I think I would add to that. I think it took some time as well. I mean, one randomized controlled trial, no matter how phenomenal the outcome, does not necessarily change clinical practice, as we all know. It took a while for, I think, guidelines, although the CDC pushes, it took a while for the CDC to put out their guidelines and recommendations for that, which then allowed a prescriber to be able to push and ensure to cover things like this. But I think the bigger issue is, in fact, patient assistance programs and things like this generally do not cover PrEP, indicated drugs, and that becomes a major limitation. As you saw, a majority of 33% of our patients in our clinic do not have health insurance, and that's a huge number. So I think it's multiple limitations, but I think providers in HIV as a whole tend to be people who are highly supportive of this, but there were many barriers along the way that led to a slow rollout. We now have our clinic at the VA and our clinic here now frequently prescribes PrEP when requested, but there are many hoops a patient must jump through, including coming back every so often, quite frequently, for HIV testing to make sure the patient hasn't had breakthrough, and which adds to the cost. So it's not just the cost of the drug, but all of the additional medical care that comes in line with the very frequent monitoring for these patients. So I think that's a major.
And just to expand on that briefly, the CDC has fantastic guidelines. So I was able, with my particular patient, to reflect on those guidelines myself and to share them with him so that he was really engaged in the close follow-up that is essential. Yes, ma'am.
So I was curious with your figure of the diagnosis by gender and the racial disparity. And if you account for something like income or some other socioeconomic factors, do you still see the same level of racial disparity in the women?
Yes. There is someone at UNC, Ada Mora, who is truly a scholar in this area, and I would encourage you to read some of her manuscripts, because Ada has really tried to tease through this. And it's not differences in sexual behavior. That's not the issue. But it has to do with access to testing, access to information, perhaps stigma, the fact that a substantial portion of the African American male population may be in prison at one time. It's really complex and includes many cultural, social factors that can create for African American women an environment of greater risk. And so I would encourage you to look at Ada's scholarship.
Thank you, everyone, for coming. I think we're going to have to stop it here because of the hour.
Oh,